First I had TB, and TB put me down. And you know, once you are down, everything stops. Then from there, multiple complications, poverty, all that.
Across much of Africa, there is a plight of pain and suffering. Famine, war, civil unrest, disease. Many nations struggle to provide even the most basic support for their people. Uganda is one such nation. Since the fall of Idi Amin and a civil war, Uganda has struggled to provide adequate and affordable health care to its 32 million inhabitants. The average life expectancy is 54 years. In sub-Saharan Africa, more than 20 million people are living with HIV/AIDS, and there are over 15 million AIDS orphans. In Uganda, in the 1980s, 30% of the population were infected with the AIDS virus. Now, a rare success story in Africa, the number is closer to 6%. But still, over 60,000 people die of AIDS-related illness in Uganda every year. Cancer is also prevalent. In the country villages, there is only one doctor for 50,000 people.
There's only one cancer centre to serve over 30 million people, one trained oncologist, one radiotherapy machine.
Throughout Uganda, nearly 100,000 cancer patients need urgent access to basic pain control. Due to the lack of medical services, extreme poverty and poor education, tumours can disfigure, rupture and cause unimaginable pain. This film documents the scourge of cancer in Uganda and the devastating effects caused by the lack of treatment and pain control.
The World Health Organization has made it clear that morphine is an essential drug for cancer pain relief. What we see in Africa, as in many other parts of the world, is that many problems and barriers in getting access to morphine. Although it's a cheap drug, it's easy to produce, and it's relatively easy to administer in trained hands. At the moment, many people who would benefit from it are not receiving it.
Stanley Kasigazi. He's 58 old with cancer of the prostate. And when he came, his major problem was bone pain of the lower limbs. Being on bed all the time, he's feeling like everywhere it's painful. Because since May has been bed-bound, so he's feeling everywhere.
I'm feeling badly. the whole body. I'm now feeling badly.
Okay, the problem now, because he has that pain, he ran out of drugs.
Before you can do anything else for a patient, you must have pain control, particularly patients who are critically ill or are coming towards the end of life. We have people coming here who are screaming or have been in agony for months and haven't slept for months. So the holistic care that is so necessary to give to patients who are so critically ill is impossible, because they can't even think of making peace with their friends, with their families, or with their God in this situation. And we can't even talk to them about the other problems. So holistic care is almost impossible unless we have pain control.
Cancer in Africa, for most people, means very poor access to the treatments that we would consider fairly standard in Western societies, chemotherapy and radiotherapy. Survival rates are very poor. Many people will present with at a very late stage of their disease. So for a great proportion of people with cancer in Africa, palliative care is the key intervention. If we can do that, we can address symptoms and problems that patients are having.
He's okay now. The pain is coming down. He's saying that as he's nearing his death, and he has some children who are still schooling, is there any possibility of helping him after his death to continue helping him with school fees and scholastic materials? Before he didn't tell us his problem, but now, because the pain is controlled, has brought up his distress now as school fees.
Now, are the children, she has two children, one is 6 and one is 3.5. Are they at home with her or are they with the father? In Uganda, there really is very little available for cancer. There is in Kampala chemotherapy and radiotherapy. There's a cancer institute. But our patients who live out here, they can't even afford the bus journey to go to Kampala. The cancer patients fall into 3 groups. The first group are those who have seen a relative with the same condition, and they say, I'm going to die, and they stay at home, and they suffer. The second group goes to a health center, and either the health center says you have cancer, you're going to die, and the same thing happens, or the health center treats them, gives them antibiotics or whatever, which doesn't help. So they're suffering at home quietly. And then the third group might go to a bigger hospital in Masaka here or near their home, and the doctors say, oh, you have cancer, you need to go to Kampala. And as I say, they go home. You might as well tell them to go to London.
With only one treatment center in the capital, Kampala, chemotherapy and radiotherapy is unavailable to most. One hope for those suffering from cancer is work done by the hospice movement, in particular Anne Merriman and the organization she helped to create. Hospice Africa Uganda has been building a unique palliative care service for the past 20 years.
When we work out the number of people in Uganda at the moment who need pain control at this moment, it's something like 200,000 people. Now, we have one doctor to 19,000, but in the villages it's 1 to 50,000. To them, cancer means pain and a terrible, terrible death.
This former nun is regarded as the pioneer of the hospice movement in Africa. In 1990, she was appointed the medical director of Hospice Nairobi, and during this time, she realized the extent of the suffering and the lack of care available for patients dying with cancer in Africa.
People were suffering all over Africa without any pain control, some of them screaming actually, and the families having to put them far away so that even the family carers could sleep at night. And I realised that this was something that had been going on for all these years. We really needed a model that would be adaptable to the cultures in Africa. And so I left Nairobi Hospice and spent a year trying to get together a group that would support us to start, and also to find out which country we would start in.
Although a poor country, Uganda has a good climate for agriculture, favouring the production of such crops as bananas, sugarcane, coffee and tea. It was here that Anne Merriman convinced the government to let her establish a model for hospice care for the whole of Africa.
We chose Uganda because it had just come out of war. The people were very, very enthusiastic and very caring for each other. And although there was you could see it was a poor country and you could see bullet holes in the buildings in Kampala, there was a feeling of hope in the country, and they had the trust of the international community, so we knew we'd be able to get funding. The three objectives was, first of all, to care for patients, and this is what we call clinical care. The patient care was to care for patients who particularly had severe pain, were critically ill in the home, or were at the end of life. The second one was to have training so that every health worker throughout Uganda would be able to manage a patient or at least refer them to the right service. The third one was to be a model for the rest of Africa.
The cornerstone of this kind of care is pain control. For the dying, dignity and comfort often means prescribing powerful drugs, of which the most important is morphine. Since it is derived from opium, it is a controlled drug, and many governments refuse to make it available for medical use, due to an unwillingness of authorities to introduce drugs that are considered to be addictive. So most Africans dying with cancer or AIDS suffer severe pain without relief.
Morphine is a very symbolic drug. It's surrounded by fears and anxieties and almost a kind of demonology. So what we're seeing is an over-bureaucratic approach to the regulation of morphine, the fear that it will fall into the wrong hands and be misused. Will it be stolen? Will it be used by people for non-medical purposes? And you see this working through in the way that governments regulate its use, in the way that physicians think about how they use it, and also in the eyes of patients and those who need it.
This is the centre of operations of Hospice Africa Uganda. It provides clinics for patients who are well enough to travel and a daycare centre. Since 1993, Hospice Africa Uganda has opened 3 care centres across the country, in Kampala, Mbarara and Hoima. Nearly 1,000 people with cancer or HIV/AIDS are on the hospice programme. Another 1,500 patients have access to pain control from medical workers trained by Hospice Uganda. Home care teams leave from here each day to visit the patients who are too unwell to make the journey to the centre.
The idea of visiting patients at home is really intended for the very ill people who are simply too unwell to either travel to a clinic or to any other healthcare facility. And oftentimes those people will be bedbound because of their illness. So the teams will travel out, will visit at home, see how the person has been since the last visit, see how the family are doing, and depending on what issues present, will prescribe and leave medication with them.
Grace is 38. She knows she is dying with terminal cancer of the cervix. Her father died a week ago, and the family are still in mourning.
So how much are you taking?
2.5.
The one I told you?
Then at night she told me 5, yeah.
So how many times, how are you taking it?
In the morning, at around 10, at 2, then at 6, then at 10.
To understand your weakness and your pain that you have, that I cannot of course understand with, because it's not me suffering, then I want you to gauge it for me Like if 5 being the worst, like has too much weakness, and 1 being the least, like 1 out of 5, or 5 out of 5 being the worst. So where would you get your weakness?
4.
4. And
Because when I'm down like this, at times I feel myself going, finding myself totally weak. I have to get up, sit a bit, relax.
Despite her father dying of cancer, Grace's mother and grandmother do not understand her illness. They are worried she is not eating and her condition is deteriorating.
She's saying that the main worry now, she does not eat, she does not drink, so they get worried. They should understand why you're not eating much and when you're not drinking much, and your stomach is growing big and big. So is it okay if I can talk to them?
It's okay.
It's okay. Kati cancer in cancer awona kubatawo. Yali eryetya mu nkwawo.
Nkwawo yali ejjanga ekizimba nefulumya ekitwe nekibanga ebbwa.
She says she had a daughter before and had the cancer in the armpit, and they did radiotherapy and it cured. So she's wondering how this one can also be helped, because they don't want to see her, die or, well, being unwell like this. So I'm going to explain her. Cancer akwata wantu wangi. Buli muntu amukwata lulwe. Cancer asobola okukwata ebbeere, asobola okukwata eriiso, owa Grace yakwata ku nnabaana. Eyo cervix. Oyinza okubuuza lwaki oli akyali wate Grace muno obeera nga buli kanaku omulaba aliki tekimulaba. Kiki ekyo?
After negotiating with the government, Dr. Merriman managed to get a license to import the much-needed morphine.
One of the big problems in providing any kind of healthcare in Uganda is the cost. Resources are extremely limited, and one of the drugs we absolutely need to have to provide palliative care is strong pain medicine. And what Dr. Merriman found when she started first was she'd had access to a formula for making up morphine, which she'd first learned in Singapore. But it means that morphine can be made up quite cheaply in Hospice Africa Uganda through importing powder from Europe and then reconstituting it with preservative and food dye in Hospice Africa centres.
We use now about 2 kg a month, which costs about nearly £3,000 a month, but in fact, when you work it out for the patients, it costs the price of a loaf of bread for medication for approximately 10 days for the average patient. Our average patient is taking 30 milligrams a day. It means now that the patients can go home and have their pain controlled in the house. Many of these patients have gone back to work because the pain is now completely controlled.
Recycled plastic water bottles are filled with brightly coloured solutions. The bottles are full of oral morphine, colour-coded for the different strengths. Green for the weakest, then pink and blue for the strongest.
Eddagala lyonna ani alikuleetera wano? Mbuuza nno. Wadde wabuuza dda?
Almansi is a 74-year-old man who has prostate cancer diagnosed some years ago. It had spread to his bones, and because of causing pressure on his spinal cord, he ended up with some degree of leg weakness and bladder and bowel problems.
Kati obuddagala bw'obumira bulungi?
Bumira.
The main issue he described was having very severe back pain when he was first diagnosed, and that has been eased down an awful lot by the use of morphine and various pain medications that he's been prescribed. So he's actually in really good form at the moment, and you can't see it because of his dress, but he's actually rather frail when you see he's lost an awful lot of weight, but he actually seems really comfortable at the moment.
saying that he doesn't have money of buying milk.
The nurse prescribing arose because there was a terrible need for people to prescribe. When we work out the number of people in Uganda at the moment who need pain control at this moment, it's something like 200,000 people. Now, these doctors out there have to do the gynecology, they deliver the babies, they do the cesarean sections, they do the surgery, the major surgery, and they look after the children who are very, very ill, and, you know, so they have so much to do that they could not prescribe for maybe 100 patients a week for morphine. So we had to increase the prescribers. So we put this across to the Ministry of Health, who took it to the Parliament, and they had this statute which allows midwives to prescribe pethidine for women in labour. And we asked them to change it so that people who we trained for 9 months in palliative care and in prescribing could prescribe morphine. So now we are increasing the prescribers slowly by slowly, very slowly.
Access to morphine is clearly inequitable around the world. Something like 80% of global consumption is confined to just 6 Western and rich countries. The remaining 20% is shared between 142 countries. It's a particular marked problem in Africa. The average consumption per person per year across the African region is 18 times lower than the world average.
Afsa, she's a 39-year-old lady. She was married and she separated with her husband. She has 5 children. Since she fell sick, they have never come to see her. I think Afsa wants to see her children and her children want to see the mother, but the father has refused to let the children come to visit her. You see, she's really very sick, but she's hanging on. Maybe she really wants to see her children. Sorry.
Hi, Mama. Ora never went to Yana. No can look to Tuka.
Nangechechi mnemesa katigwa na pulumatinga taina kali.
Checho. Samunana. Apati. Kintu bwechugira. Mwongera mkatsa 12 wezi nawe. No, she could be having a headache and I think she has malaria and she said, well, they might be having malaria as well because they sleep near the river and the mosquitoes bite them. And I was asking about the net, the mosquito net, and she's like, I have feared to sleep in a mosquito net. So that's why we had reached trying to find out why she fears the mosquito net. Fear is a problem of fire because in the process of the night, people sleeping, waking up, and put on a matchbox and it catches them. And they all get burned. It's also another worry.
In a busy western suburb of Kampala, Mulago Hospital has a cancer treatment centre. Burkitt's lymphoma is a curable form of cancer that doctors often see.
Burkitt's lymphoma is extremely common in Uganda and actually in a belt across Africa, and so much so that Burkitt, who actually described it first in Uganda, thought that it was related to the mosquito or to malaria or the Epstein-Barr virus, and we've never actually got to the bottom of it, what it is really related to. But it's a tumour of the lymphatic cells, and many of the children present with a huge growth on one side of their face.
Hospice team member Dr. Charles visits the centre 3 times a week. The hospice provides not just pain control, but also pays for the first course of chemotherapy in an effort to cure these children.
Okay. The mother is telling me that he's now feeling a lot of pain. The tumor was a bit small, but now it is increasing in size. Otherwise, she has been here on the ward for the last 3 months. She has been here on the ward. Yeah. Leaving her family at home. They have these kind of deadly diseases, but affording the treatment is a problem. It's a problem. Most of our children on this ward, they come from very poor backgrounds. I should say like 95%, they are below the poverty line.
It is actually a highly curable tumour, provided they have the right chemotherapy. And a course of chemotherapy over 6 months costs approximately 100 to 200 euros. But the majority of parents bringing their children to Cancer Institute can't actually afford that much for chemotherapy. And I think it must be absolutely unimaginable to be a parent and to be told that your child has a curable tumour, but to find that they're going to die because you can't afford the medication for them.
Because like out of 10 children, you can save like 2. So it is just a matter of time. Eventually they die.
Once a small fishing village, the southeastern city of Jinja has benefited from being located on the trade routes between Kenya to the east and Uganda and Rwanda to the west. It lies beside the source of the River Nile, and locals say that it takes 4 months for one drop of water to meander the 6,695 kilometers north to Egypt and flow into the Mediterranean Sea. Outside of the city, in rural areas, people like these sugarcane farmers survive on subsistence farming and trading in local markets. The average household income is about €6 a month. Access to healthcare of any kind is difficult and mostly unaffordable. With this in mind, Hospice Jinja was founded in 2005 to meet the palliative care needs of patients with advanced cancer and HIV/AIDS.
Like the rest of other hospices in sub-Saharan Africa, we focus on cancer patients and also on the terminally ill HIV and AIDS patients. And right now, as we speak, 55% of our patients are cancer patients and the 45% are patients with HIV and AIDS.
The Jinja Hospice was started with the help of local and international fundraisers and supported by people like retired Irish doctors Frank and Patricia Hassett. The size of the area the hospice covers is vast, so they have developed a unique system of community volunteers to help identify those who are in need.
We go to the village and we talk to the village leaders and we ask them for the community to choose people who they would like to help them if they were sick. So 2 or 3 come from the village and they come to a special training course in which they learn basic nursing skills, how to care for patients in the home, how to make the bed over a patient who can only lie on the floor and things like that. So it's very practical. But they're also taught when to refer patients to us which are needed. The patients who are in severe pain, patients who they suspect have cancer or have HIV. And we will meet them once a month to see if they're having any problems and to give them continuing education. They don't get paid, but if we have a donor who will give it, we are able to give them a bicycle after 3 months. Good care.
Once identified by the volunteers, hospice staff visit those who are too ill to attend the outreach centres in the rural villages.
Mr. Sulaiman Chinabi has been on the hospice program for the last 3 years. He was diagnosed with the cancer of the breast, and since then we have been taking care of him. By the time we met him, the disease was already advanced, and the best way was to palliate his symptoms and challenges that we were going through. Tuwaire kuku obulwaire bwe buli butya oli kuwulira otya. I'm asking him to tell us how he is today So the bleeding is controlled from the tumor, but it produces some fluid. Number 2.
But ever since hospice started treating him, they really help us. They give him good treatment. When sometimes Mzee can be there crying, saying that I'm feeling pain, but the treatment, it's very good. Mzee is a person who has used many treatments from other places, but hospice, it's a very good treatment which they give him. It has really helped him.
Mami Chinabi, ate obulumi bwo buli butya?
Obulumi bwene genkozesa.
So when asked about his pain, he says his pain when he takes the oral morphine is controlled since he does it 5 times a day, and he was explaining to us how he does the 5 times. When we met him, the tumor wasn't as big as that, but as we say that the cancer is continuing to grow. But in the first case, his major problems were pain and a foul smell that he was getting from the tumor. Okuwuna kuli kutya?
Okuwuna nga wena mpigano buli kuwulira ngera bw'obaawo ano bulido singa ano oliku singa enindo ogikole.
When asked about the foul smell from the tumor, he says if it were smelling, every one of us would have been. So, but it's not there, and so it is also well controlled. We really see that actually his symptoms and the pain in general are well controlled. The family is very supportive. The community has been supportive. And everybody in the community often wonders what actually hospice is giving him, so he has been alive for all these 3 years. And they think we are using something miraculous.
Even many people, they ask, what treatment do you use Mzee to stay right now? But we tell them, just go to people of hospice. They have good work, they appreciate with people. You explain everything, she or he can listen. We don't even call them doctors, we call them family members. The way how they treat us, the way how they take us. They don't take us like people who are maybe patients. They take us like family members.
Unlike Hospice Kampala, the local government imports the morphine powder. Due to inefficient administration, the teams face running out of morphine on a regular basis. The doses are carefully rationed, which can frequently result in patients running out and suffering extreme pain for days.
One of the problems that people on the ground face is the supply line. Sometimes money is available to purchase drugs when there are no drugs. Sometimes the drugs are available and there's no money. And the consequences are very bad for patients who can suffer immeasurably when the drug is just not available on a given day.
Florence Nandogo is 46 and has been diagnosed with a nasopharyngeal cancer.
When she had the oral morphine that we gave her the last week, the pain was controlled and she was able to eat some food. But now, 2 days, the oral morphine ran short. She no longer has it, and so the pain is back in full swing. So we straight off give her a dose of oral morphine to help her to kill the pain straight off. No, it's okay. They are asking her about the nose bleeding, and she is reporting and saying that after we met her last week, after that time, the bleeding became very severe, and it was too much that she thought maybe she was going to die then. And thank God it's later reduced on its own, and now she's having kind of bleeding still, but like the normal that she usually experiences, a little bit just. The levels of prognosis are also determined by what other treatment options you take up. So assuming maybe she had had a radiotherapy as she was suggested 1 year ago, maybe she would be a little bit better. So it seems she doesn't have a lot of time left.
For most of the people that the hospice cares for, radiotherapy and chemotherapy in Kampala is geographically and financially out of reach. Eventually they die, leaving family and friends behind.
After a person dies, the remaining family are bereaving and grieving the loss of their loved one, and it's really important that they receive support. And that has always been a feature of palliative care, and it's equally a feature of palliative care in Uganda. So typically after somebody dies, the team will go out and visit a few days after the funeral to offer their condolences to the family. And it's really a way of sharing their loss. And people find it very supportive, and again, I think find it really helpful that team would take the time to come to them. I think it helps them to feel that the person who's died was very valued by the team, and that they themselves are valued by the team, and they derive a lot of support from that.
This is what we call a bereavement visit. We come and share a moment with the family, and we ask how the patient was before he or she passed away. And we also bring in our condolences as hospice and the team. And so we came along with other patients, and so they can also be able to sympathize with the rest of the family.
More than 1 million people have died of AIDS in Uganda, and it is estimated that another 1 million are living with the disease. In spite of the availability of antiretroviral drugs which stabilize AIDS patients, more than 60,000 Ugandans still die from the AIDS virus every year.
In 1993, 30% of the population here were HIV positive, which meant in those days very few people lived more than 7 years after they were diagnosed. Many died within the first year, and they died of intercurrent infections which were very painful, such as cryptococcal meningitis, which gave them severe headache.
It's a huge problem because it predominantly affects young and middle-aged adults, which means if they become too unwell to work, it has huge implications for all their families. At those ages, people are typically parents, and there's a high birth rate, so family size is big, and if people become too physically debilitated, which they often do with HIV/AIDS, it means there's no income coming into the house.
AIDS was a huge problem, and Museveni was a very astute politician, and he looked at the problem and he said, we can't manage this. So he turned to the outside world and asked for help, and that's why Uganda is probably much farther along than many, many African countries, because they recognized AIDS, they said they had AIDS from the very beginning, and they did something about it.
In those days, there was no antiretroviral drugs. These are the drugs which allow patients to live a life, and many people nowadays on antiretrovirals would not die of AIDS at all. They'll die of something else. So it's no longer a life-threatening disease, as long as you can get a permanent supply. But for the rich, that's permanent. For the poor, they may get it and then it may stop, and that's a difficulty too.
Margaret was diagnosed with AIDS 4 years ago. When they found her, she was debilitated, emaciated and bedbound, with multiple bed sores and her joints frozen, unable to move.
At what is a problem? What's the problem?
Problem in magulu.
The pain in magulu.
How does she describe it, Charlotte?
She says it's feel like something deep-seated. It's not throbbing, it's not pricking.
Okay. Is this pain there all the time or just when you lie on that side?
All the time. Even now there's pain.
Margaret has severe bed sores on both hips. They have dramatically improved since the hospice first started treating her.
These are therapeutic marks. Sometimes people use traditional medicine, they apply topically to near where there is maybe the affected area or the affected part of the body.
Is it painful when you move like this for us? The other one, the skin is closed over, but there's still an open area here. But it is improving, you know. I think it was very wide.
Yeah, it was.
Yeah.
It really was very wide.
Sorry?
Yes, she does it on bed.
But it was helping.
Pain and discomfort from her illness are not the only challenges Margaret faces. When she first fell ill, her family isolated her in a room.
And she wasn't happy. She was like, no, why should they use gloves? She was touching my hand, could I infect them? And it could hurt her. She could not even eat food. Many times she would refuse to eat food because even the food they'll bring with the gloves. Even lifting her, they were touching her, cleaning her without a discharge or what, they would use gloves. And she wasn't happy. So every time she would be too emotional about it. Even to express this to the medical team when they come here, it would be hard for her. She would say, oh my God, what can I do? What should I say? And you find that now we're dealing with social pain, not physical pain. And we had to, of course, do family meetings, part of our care, that we have to meet the family separately. We tell them how the patient is feeling, and we work together and see how we can actually help her. Being HIV, and she could not walk out of the home to meet the services of HIV. So she thought she had lost hope of her life. And she was like, now hospice come in the home and you make me sit, and it's really great because it means that there are people can survive. You can live.
Gloria is HIV positive, and she has been attending the clinic for 3 years. She's now 20, but due to her illness, she lost her sight.
I woke up one morning when everything had turned black. I stopped going to school and I lost contact with my friends. I felt like the world had come to an end.
Gloria's sister, Mary Ann, is her full-time carer. Their mother has left, and their father wants them both out of the house. Mary Ann was forced to give up her studies to care for Gloria.
So do you regret to have stayed for Gloria's case to take care of her?
I don't, but then there is this feeling, at one point you're like trying to talk sense into this person. There comes a time when they don't really consider my input. You tell her this and she shouts back at you. They tend to forget that I am a sister, older than any of them.
We always tell you that we care for the family and the patient. This is a home visit, and we always want, these are things you cannot sometimes air out in hospice. So Gloria, do you appreciate what your sister has?
Yes, very much.
When we need another hand, for instance, when there are chores to be done, we need another hand. So you can like ask for her help. And and she's like very stubborn. Then that is when I also say something.
Gloria, what do you do here at home? When you are very comfortable, no pain, no what? What? Tell me.
I can sweep that.
Sorry, Maureen. Sorry. No. Sorry,
It's okay.
Gloria, what do you do here?
I can sweep the garage.
Can you make the room neat?
Yes.
Can you
sometimes.
cook? Why?
I'm afraid of fire.
You're afraid of fire. So you think you can fall into fire?
Usually we use a stove. I cannot light it because I cannot be able to see the words.
Dr. Anne Merriman has established a model of hospice care now being implemented in countries across Africa.
And it's a huge achievement because, as well as setting up services that provide direct palliative care and setting up high-quality services that are affordable, an education system has been set up that has trained over 17,000 healthcare professionals since the hospice started in the 1990s.
This new education centre provides training to healthcare workers from Cameroon, Malawi, Sierra Leone and Sudan.
Now, all the doctors who qualified since 1994, they know what we're talking about. But we also started teaching in the nursing schools, training courses for health professionals, for traditional healers, for spiritual advisors, and we see the future of palliative care as being carried forward by those we train, not by our own service.
Uganda has demonstrated superbly that you can overcome these problems, that you can prescribe morphine, you can make it available to those who need it without it being stolen, without it being diverted into the wrong hands. It provides reassurance that this can be done in countries with very small resources otherwise.
Hospice Africa Uganda is now a proven model for palliative care that can work across much of Africa. However, in Uganda, there are still many without sufficient access to health care. After recovering from leprosy, Josephine Namaranya now has cancer in her feet. Her 6 children died of AIDS, and she now cares for her grandchildren.
The children from school whom we met out there, they are her grandchildren. They live with her in this house. Yeah, this is a very big problem in her because these are very young children now whom she has. Josephine. She used to get her drugs from Mbara Regional Referral Hospital. That's where she got her drugs. Except now when she developed this, of course she couldn't go for further treatment. They said they don't have drugs for cancer. Because all patients who have cancer this end, they're supposed to go to Mulago. Mulago is the only place where you get chemotherapy, you get radiotherapy. So that's why we have so many patients here who they present when the disease has developed so much. It's because they keep going and they tell them you go to Mulago and they cannot go to Mulago. Either they don't have money, they fear they're going to the Mulago, and they just stay here. You see, sometimes people who live like here, they wouldn't know even the town in Mbarara. So now if you tell them you go to Kampala, it is a total dilemma. As much as they don't have the money, even going there, no place to live in, they don't know anybody there, they just don't feel like going there. And remember, at that time of the stage of cancer, when it hasn't developed, it's not even painful, so they don't see any reason why they should go there. Just telling somebody, you go to Mulago, sometimes they feel like now we are just trying to abandon them. Because we can't do much. You're supposed to go to Mulago. If you don't go, that's your fault. But it's not their fault.
The World Health Organization says that chemotherapy and radiotherapy won't be available in Africa for generations.
There is hope. One of the really exciting things that's happening at the moment is the idea that we can start to think about freedom from pain and access to pain medication as a fundamental human right. A number of lawyers, philosophers, activists of various kinds are working towards building up a case for the recognition that freedom from pain and access to pain medication is a human right. This is a much more powerful argument than we've ever had before, and it's getting listened to in places where palliative care was previously ignored.